Good afternoon, Dr. Swan. Welcome. And as you know, you have 10 minutes for your presentation, followed by 5 minutes of questioning. And this round questioning will be coming from the government side. You may begin anytime. When you begin, please identify yourself for the purpose of the answer.
First of all, thank you on behalf of the Ontario Association of Cardiologists for the privilege of coming today and explaining what's happening in cardiology. As you sit around the table today, you know the number one killer in Ontario is actually heart disease. Congestive heart failure is the most expensive disease that we treat, and the majority of these patients often end up in the emergency department. And when they go to the emergency department, the cost rises. So we want to try and keep these patients out of the emergency department. Cardiologists are doctors who treat cardiac disease, and they're experts in the treatment of cardiac disease. And we deliver thousands of services throughout this province each day, whatever time it is, 24/7, 365. Yet in the last year, the Liberal government has made, on 3 occasions, cuts to the fees that are paid to cardiologists. And this fee cut not only applies to other physicians, but disproportionately is affecting cardiologists. As you know, there's a 4.45% cut on the global billing cap to all Ontario physicians. But what this government has done is it has cut the payment for services that cardiologists provide to the heart failure patient, the E078 code. Some of you may be familiar. And when you look at some of the additional cuts to non-invasive cardiac testing, it totals 25% when you add the 20% to the 4.65%. We feel that this is very unfair. This is poor health care policy and poor physical policy. It's poor health care policy because the cuts have forced cardiologists to scale back the outpatient services they provide, thereby reducing patient access to community-based cardiac care. These cuts have fundamentally undermined Ontario's outpatient cardiac infrastructure, and as we speak, it's headed for the brink unless something happens. This infrastructure is something that cardiologists partnered with government, outpatient infrastructure I'm talking about now, over the last 20 years so that patient care could be delivered much closer to home. It's poor physical policy as these community-based cardiac services recede. Cardiac patients must now go to the hospital for care, which is more expensive to deliver in the end. We can't battle Ontario's number one killer with continued unilateral, systematic government cuts to cardiology physician services. With this in mind, the Ontario Association of Cardiologists urges the Ontario government to use the 2016 Ontario budget to aggressively fight Ontario's number one killer by restoring funding to Ontario's crucial cardiac outpatient care infrastructure and working with our organization to ensure that patient access to cardiac care in these uncertain economic times is protected and not jeopardized in the future. You might wonder who the OAC is. The OAC is a voluntary professional organization of the cardiologists in Ontario. We represent the majority of cardiologists, whether you work in the academic or community environment. Our goal is to protect the current high standard of cardiac care that we deliver in Ontario, to protect the patient, but also to make sure that the cardiologist who's delivering these services is fairly remunerated for the services. You might ask why the Ontario Medical Association is not here arguing for the patient. If you look inside the structure of the Ontario Medical Association, you'll find that the financial resources nor the infrastructure is not there to protect the cardiac patient. And that's why we exist outside the Ontario Medical Association. The Ontario government has promised to balance the budget by 2017-2018. According to the most recent plan, the government will run a deficit of $7.5 million in 2015-16, 4.5 in the following year. We at the OAC agree that the government must live within its means. We support a return to balance as soon as possible. What we don't support, however, is the elimination of the government's deficit on the backs of cardiac patients, many of whom are sick and vulnerable, and also on the backs of hardworking cardiologists in Ontario. Just to highlight the cuts for the elimination of the 078. So this means that the complex heart failure patient, and many of you in the room need to understand what a complex heart failure patient is. These are people that will require expert care in the community to keep them out of the hospital. You cut that code for the doctor to look after the cost. So these people are headed back to the emergency department. More dollars are spent unnecessarily. You cut the fees for the delivery of non-invasive cardiac services, nuclear cardiology and echocardiography, so we can make the diagnosis and manage the patient. 20%, add the 4.65, 25%. That infrastructure that we worked with you to develop over 20 years is decaying. The across-the-board cut to physician services, we as physicians as a whole feel it's unfair. If you look at your cuts to date and where you're headed with your budget, our estimates are you're going to have to come back and cut more services. And we think as cardiologists you're going to single us out again disproportionately to other physicians. Minister Hoskins has called the government cuts to physician services a modest reduction. I challenge you, Minister Hoskins, to say 25% is a modest reduction. If I cut your salary by 25%, I don't think you would agree. The minister claims that the government is not actually reducing physician services, but increasing them by 1.25%. Remember that each year the population of Prince Edward Island moves to Ontario, and we're asked to look after those people without any increase in funding. So you can see when you do the math that the minister, I think, has it wrong. Cardiologists add tremendous value in this province. We save people's lives every day, 24/7. And when you meet us in the emergency department within minutes, sometimes we're in the process of saving your lives. Otherwise, you meet us other places and we improve the quality of life for our cardiac patient. Now, cardiologists, whether you work in the community or in the academic environment, we're small business people and we have to pay our overhead. And our overheads, when government talks about income, you talk about gross amounts. You don't talk about overheads. Our overheads are between 35 and 40%. Just to highlight for you, in the last 7 years, a regular staff person working in our clinic or in our office environment, their salaries have doubled. We've had to eat that amount. We have to pay for the computers, the medical supplies, the medical equipment, our office insurance, our rent, and our service contracts, in addition to continuing medical education. So when you think of doctors' income and cardiologists' income, it's not the top number. You have to look at the bottom number, and then you have a realistic idea. Unlike independent businessmen in the community, we can't change our fees. The legislation does not allow us. So we're fixed in this particular situation. Cardiologists, as I've said to you before, they add tremendous value throughout this province. Many of you have had a friend or maybe a relative who's appeared in the emergency department with an acute infarct, and within minutes we have you in the lab, we have an artery open, and we save your life. Sometimes people come to us and we think they're dead. We take them into the lab, we open up an artery, and amazing, the heart starts to beat and they start talking to you. This is the kind of work we do every day. We also take complex patients who can't walk 10 or 15 feet, and with new procedures, we give them special pacemakers, and we have many of them get back to almost normal lifestyles. We are a very hard-working group, and we're committed to our patients, but we can't continue to suffer these cuts any longer, or we won't be able to deliver the services in the community. And just to highlight again for you what we'd like, there's two priorities. Number one is get rid of the cuts that you've given us in the last year to cardiology services, the cut to the congestive heart failure patient and the cuts to the non-invasive testing. You need to restore that funding for the E078. We did a study and we went and tried to work with government. We brought to you a solution. Do you know that if you keep a simple heart failure patient out of hospital, you save $12,000, and if it's a complex, it's a minimum of $42,000? Yes.
Thank you.
I can. So in conclusion, what we're asking for is the government to care about cardiac patients and to take action as I've outlined. Thank you.
I'm going to turn to Mr. Melchin to begin this round questioning.
Thank you, Dr. Swan, for coming this afternoon and taking time out of your practice and your personal life. And we do certainly appreciate the hard work you do for all of us and our families every day. I wanted to ask you a few questions around the use of new technologies in
Sure.
practice. And I've seen some figures over time about the increase in costs that relate from new medicines, new technologies, and that obviously has an upward pressure on our budget. And I've been told that in the realm of cardiac care, there's been an increased use of things like cardiac MRIs and other technologies. And it's not to say that we don't want progress and we don't want the best that we can for our patients, but has there been an assessment of patient outcomes versus increased reliance on new technologies and cost to see whether we are being as effective as we can with scarce resources?
Well, I think in Ontario we haven't done this study, but it's been done elsewhere in the world. And to give you a very simple example, you could take a person with a hypertrophic cardiomyopathy, and Toronto is...
Could you just explain what that is?
I'm just going to explain it to you. A hypertrophic cardiomyopathy is someone who's born with a congenital abnormality of the muscle of the left ventricle, and Toronto is a world leader in this particular area. And what we've been able to do with MRI is we've been able to better risk stratify those patients so that we can determine what their outcomes are going to be, and also then tag the appropriate mechanical devices that those people may need as they go forward. It allows us to make new diagnoses and better understand how to manage that patient. One of the things we have in Ontario, and your government supports it, it's a program called Choose Wisely. And what Choose Wisely says, you should do the right test at the right time on the right patient using the right equipment and for the right reasons. And I think that's how cardiologists work each day. So it doesn't matter which technology we use, whether it's a non-invasive or whether it's an invasive, we try and do the right thing each day. So one of the things that you have to do, and you're quite correct, how do we marry these technologies forward? So we have guidelines, and we practice evidence-based medicine, and each of the doctors in cardiology that I know, that's how we practice. So if the evidence says that you need this, then we're going to get it for you. Now, the wait time for some of these tests is very long, and sometimes what happens with the wait time, sometimes not so good things happen while the wait time is there. But then when we get the test, often we can change dramatically how that patient is managed in the future. So these new technologies have helped us tremendously.
And now I understand that in your particular specialty, there's something called technical fees.
Yes.
That you're paid, and most other specialties don't have them. So could you explain that?
Well, the technical fee is the fee that the doctor or the lab who's running the test receives to operate that particular service. So it covers the cost of the equipment, it covers the service contract, it covers the technicians involved generating the report. All of those things it covers. That's what it covers, the technical fees. Now, if you go back and look at technical fees, there hasn't been any increase in technical fees in over 20 years. So when you look at people trying to provide these services, whether it's in a hospital or outside, and remember, the hospitals need the outpatient services to help support providing the non-invasive testing. And in the community cardiologist's office needs the support of those technical fees to go forward as well and keep those services present. And the infrastructure that we have for testing in Ontario is something we built up over the last 20 years. And one of the things I'd ask you to pay attention to is there's a new document. It's called the Standards for the Provision of Echocardiography. And as of the 1st of April of this year, all the echo labs, whether they lie in the hospital or outside the hospital, will fall under those guidelines. And those guidelines are a more stringent access to the testing. And we as cardiologists think that that's a good thing, and that's something we've worked together with your government in a positive way on. So for nuclear cardiology, there are standards in place, and in the other non-invasive testing, where there isn't standards, we will work to put the standards in place. But the thing I want to impress most on you today is the heart failure patient, that very vulnerable heart failure patient, the complex patient. Your government is ignoring the care. We have data. You want data, we can provide you with data. Since you cut the E078, those patients are showing up in the emergency department
thank you for your
more often.
presentation, and thank you for your written submission.